functioning. I think especially crucial in what I would say was especially crucial in your effectiveness was that you were presenting yourself as a whole person to a whole person. You were not coming from a hierarchical stance with the client. You were not presenting yourself as the expert, and you were recognizing that the client had to lead the way, and you were able to follow. At the same time, you had a scientific awareness and attentiveness as you were assessing constantly and responding. I think your strengths focus and your acceptance, your lack of assumptions, and the way you moved from joining with him all the way through to having him look at a final plan really reflect what, and again, like you, I don't want to separate fields anymore. This is all mental health, this is all, you know, this is all life, working with people, helping people. In social work, we might call an ecological perspective. Is there anything in what you were doing with LC that you feel is especially more related to addictions than to someone with any other problem?
That's a good question. Yes, I'm not. When we try to customize therapy, we try to tailor it to a person with a problem. As you say, a whole person treating a whole person. Everyone smiles as you say that, and yet as you reflect upon how we carve up the field and write about things, you would just think these are disembodied treatments applied to discrete disorders, like someone threw a DSM at you or something. In addictions, the relational preferences of virtually all patients are for more egalitarian, empowering stance. And that's one personally I value. There are those moments, if you saw me in another therapy session, however, I would, because the moment demanded it, take a more hierarchical position. For example, dependent patients come in acute distress, and it is helpful at times to say, I am an authority, and when I ask what they need right now, they essentially say, take charge. Because of my personal value system and perhaps my personality, my typical response is, I will in the short run, because I see this would really help. In the long run, however, I would like to suggest that perhaps one of our therapy goals is that we become more egalitarian, and that in the long run that you become your doctor, and that I be more of a resource or as a coach. So though I personally favor egalitarian perspective, it seems to be far more congenial for patients struggling with addictions than some other problem behaviors.
Follow up on that. On the other hand, you are, what we used to say in social work all the time, is starting where the client is.
Yes.
And you're continuing constantly to define his uniqueness and his individuality where he is at the moment and responding from moment to moment as he changes.
Yes. And following or tracking the patient is absolutely essential if you are going to tailor the therapeutic relationship to the patient. It may also be my wife's pervasive influence as a social worker.
Oh. Good company.
The time sure has gone by quickly. We're near the end of our program, and wondering if there's any final questions or comments or ideas that you'd like to bring up that we didn't get a chance to talk about.
Well, I think my closing sentiments here are first my appreciation again to LC. It really takes an extraordinary amount of gumption to put yourself on videotape. I'm also really quite impressed with the audience question and your fine questions as well that seem to have highlighted some of the things I was hoping to present. And finally, it was in response to a question. Just the way this is, it is an open, trans-theoretical dialogue, an exchange about ideas where people aren't getting defensive, but saying, here's a straw man, here's an alternative way. Much of my research is on psychotherapy integration. And this is precisely the model or a template for us to collegially enlist each other's strengths, look at it differently, and perhaps arrive at a more holistic and, of course, effective way for seeing individual people.
Well, thank you for taking us through the stages of change and hopefully leading us to take action in our own clinical practices with your ideas.
Well, thank you, John, and thank you, Judy.
Thank you. Hi, I'd like to welcome you to our program on addictions. Today we're going to be talking about stages of change and a trans-theoretical model of treatment of addictions. Judy, what contributions has this approach made to the field of addictions?
It's become more important every day as more people have realized that what we used to do, I think, sometimes in addictions inadvertently was we would have a particular kind of approach, and if the client didn't fit, if the client wasn't in the right place for that, then we would have to wait. With this trans-theoretical approach, which, since it's trans-theoretical, we know that that means that people from a lot of different theoretical perspectives are interested in it. With this, we take the client from where he or she is and fit the strategies we use to that.
I especially like that because we almost assume that people are ready to change just by the virtue of the fact that they come to see us, or the ones who maybe are forced to come or mandated don't want to change. And this gives us a continuum for how to look at the change process.
Yeah, for a long time we had nothing to offer somebody who didn't want to change except trying to force them into what we were ready to give them.
Yeah. Why don't we bring out our guest, John Norcross, and learn some more about this approach. John, welcome.
Thank you. Judy?
John, could we start out with having you maybe just give us a little bit of an overview of the work that you've been doing recently in this area?
Certainly. For the last 20 years or so, we've been researching and applying this trans-theoretical model. Simply that people present, as you've already said, to therapy and in their own lives in different, what we call stages of change. Everyone comes to a different place. The pre-contemplators don't acknowledge their problems. Historically, they've been called people in denial, but we try to avoid that term. It's pejorative, and hardly anyone likes it if someone comes up to you and says you're in denial.
So that's the first stage, is pre-contemplation?
Pre-contemplation. Now, most people historically would have called it denial. Then, over time, and with some assistance, therapy or on their own, people move into contemplation. I have a problem, I acknowledge it, but I'm not ready to change yet. In fact, most of the people who present for treatment are, in fact, in contemplation. They know the problem, they like to change it, they're not quite sure how to get there, or not confident. Over time, they begin making small baby steps into the third stage, which is preparation, made famous by that movie, What About Bob, in which a patient, baby steps, baby steps. You're not ready to jump full-fledged into action, so instead you make these little movements and go back very tentatively and anxiously. Over time, with some success and additional commitment, people really fly into action, which most people equate with the entire change process. But as you can see, it's much broader than that. And as you said earlier, most of us would like all our patients in action. They're easier to treat, the outcomes are much better, and that's historically where we are. Once through action, though, we know it's the next stage is maintenance. If you look at the literature, we should all be embarrassed to assume that once people changed in the past, they remain changed. We now know the relapse rates, or as we prefer to call it, the recycling rates of addictions is at least 2/3 for a year. 2/3 of patients are going to relapse, or at least slip. So maintenance is a terribly important stage that has been historically neglected. So in this process of change, pre-contemplation, contemplation, preparation, action, maintenance, and then depending upon the person and the problem, maybe even termination out of the problem cycle.
So then are the techniques that you use or the strategies you use matched to those particular stages?
Exactly right. We call that stage matching. Both treatment strategies and relationship stances differ depending where the patient is.
Can you give an example?
Sure. Well, for example, the patient that I interviewed, LC, he presents in the maintenance stage with regard to his cocaine abuse. He has been abstinent for over a year, and he's working on to prevent relapse. So my relationship style with him is much more as a coach, an experienced consultant saying, let's look at your relapse prevention plan. How are we going to avoid slips? On the other hand, he is only in preparation with regard to his alcohol abuse. He knows it's a problem. He's tried to cut down a little, but and you can see it, he's a little anxious. At that point, I'm much more of a, let's call it a Socratic teacher, where awareness, small baby steps, helping him develop a plan. And even for other, like most people, he presents with a multitude of problems related to his addiction. He's also in contemplation with regard to what he wants to do with his life, his job, his relationships. So there we are much more in the way of a nurturing parent, helping him understand his goals. So the treatment strategies and my relationship stance just move along with the patient.
So even with one client, you may use different strategies depending on the particular issue that you're talking with him or her about at that moment.
Exactly.
And where in the stages of change he or she is right then.
Yes. Intuitive, experienced therapists do that automatically. In the trans-theoretical model, we hope to be just a little more explicit. And after a while, we actually educate the patient about the stages so they can realize there's tremendous transfer generalization from solving one problem to a next.
How does your approach conceptualize addictions then?
Flexibly and commensurate with the client's perspective. Much like the stages of change following the patient, we think the conceptualization of addictions should be tailored to the patient. So if he or she prefers to think of it as a medical model, we're fine with that. A behavioral disorder. Our model is a model of change, not psychopathology. And we should all be very wary of imposing a model of behavioral disorders onto a patient.